All right, so let's talk meniscus for a little while. I know, your favorite subject there, isn't it? New Orleans. It's always New Orleans' favorite subject is the meniscus. So anyway, so what happens with the meniscus? Maxx Crosby was actually not a Raven. He almost became a Raven, came this close to being a Raven. What happened? I'm Doc Faisal, orthopedic surgeon with Move Smarter Health. We are sponsored by an educational grant from Kinesi Movement. I love sports. I love talking about injuries. I take care of shoulder and knee injuries, and I operate and treat on them. And please consider this an educational, informative video only. Here we go. We don't know exactly, but what was sort of out there is that he had a meniscus injury that was a cleanup, and when they went to the physical examination by the Ravens docs, the contract was considered null and void. They decided to cancel. They decided not to do the trade. They took someone else, took back their 2 first drafts. And so now you have Maxx Crosby, who's a Raider. Actually, he never left being a Raider. And he has incredible potential, good athlete, but what exactly happened? Well, again, in the context of this injury, these are all supposition and theoretical observations based on what it could be. Now, young athlete in his 20s. Late 20s, right? So young athlete, late 20s, with a meniscus injury we don't know the details of. We don't know what other associated injuries. We don't know if there were chondral impact injuries, chondral injuries, osteochondral fracture, or any degenerative injuries. What we do know is that somewhere along the line, whether it's a rumor or not, that he had some degenerative changes they were concerned about and decided not to nix the deal. So what does that mean? What could it be? So what we do know is that he had a cleanup. Again, I put cleanup in quotes. You can see they're floating, right? Cleanup in quotes, right? Right? Can you put that in? Good. He was on crutches for a couple of months. Now, typically, if it's just a minor meniscus cleanup, crutches may be for pain, but I typically want my patients to start walking, ambulating, getting off the crutches as soon as they are comfortable. You want to just get over the postoperative pain. You don't want to be limping. You don't want to be walking and putting yourself at fall risk. But structurally, if it's just a cleanup, there's no reason to keep you on crutches for 2 months, unless it's pain, unless there was a complication or other things. Now, common things being common, meniscus surgery typically, transpires relatively smoothly without any major complications. However, things can happen. So again, we don't know the specifics of his particular surgery. This is a contextual example relating to that. I am not his treating surgeon. So we can just theorize and create a probability matrix in your head about what could be going on. Now, if I'm going to put someone on crutches for 2 months, they've had a meniscus repair and they've had something else associated with it. Did they have a chondral repair? Did they have anything else? Was there, say, a microfracture procedure performed? Was there significant chondral fissuring or chondral impact injury, or maybe a fragment of chondral, a chondral fragment that got displaced and disrupted without any blood supply, had to be removed or excised, or was lodged somewhere, or was nowhere to be found? That can sometimes happen. You can get fragments of cartilage that may have ripped off at some point, and they get lodged somewhere in the belly of the knee, because there are so many areas where in the capsule where it can lodge, somewhere in the back, into the fat, on the side, in the gutter. And even if you look all the way around, sometimes, and this is where, I hate to say it, but surgery sometimes can become like a video game, because what happens is sometimes you'll find a floater, and then because of the fluid going in and the fluid going out, in order to observe what's happening inside the knee, that fragment could suddenly float away, and then you go chasing it, and the suprapatellar fat pad is common, and then depending, it can scar down, you can get adhesions. If he gets stiffness and he doesn't move, then all of a sudden you can never find it. Right? So that's another possibility. And if he had a significant meniscal injury and required trimming, say he was back, and say he didn't get a repair, and there was minor chondral injury, we know that he's going to develop some degree of joint degeneration. I mean, athletes brutalize their knee. Volleyball players, basketball players, soccer players, I mean, jiu-jitsu. I mean, they're brutalizing their knee at a young age, and then they will, more than likely, anywhere from 70 to 90% of the time, develop degenerative arthritis, maybe 50%. I don't want to lock myself into that, all-encompassing box that someone's going to be, no, that's not true. There's statistical evidence. I get it, but statistics is a probability matrix of possibilities depending on the study that you review and what study and the validity of that study, as well as the inclusion-exclusion criteria. So any study could be questioned in that manner. But let's just say there is a certain percentage that develops arthritis in those patients with meniscus injuries. We know for a fact that if you take out the whole meniscus, which was done 50 to 100 years ago, that you will get arthritis, guaranteed. How much of this meniscus was removed? We don't know that. And depending on how much was removed, how aggressive was he in his recovery? And did he have another injury? Now, maybe he didn't have an injury training or on the field. Maybe he had it dancing at a friend's wedding, or maybe he had it just squatting down to pick up a case of beer or a case of diapers. Well, diapers aren't that heavy, so Similac or some kind of infant formula. I have no idea if he has a kid or not, right? But whatever it is, you're picking up something heavy, you crack something. Go skiing, snowboarding, whatever it is. Maybe you did it recreationally. Now, I know there's limits on what athletes are willing to do. Recreational sports aside, maybe sports cars they'll still do, but they don't want to have another injury. But if they do, and if the meniscus, say, was friable, but say it didn't have a split tear, it didn't have a horizontal cleavage tear, whether you take the upper leaf or the lower leaf, data is variable on whether that makes any difference or not, or what results in certain degrees of arthritis. Was it a radial tear? Was it just a trimming with a radial tear that you got to a smooth edge, but then it spread? What happened in the intervening time between his surgery, his recovery, and being seen by the Ravens? We don't know that, and I think that's private confidentiality, health records, and only what he and his doctor and the team decide to release. I think that's reasonable, that's fair. We don't have to know everything, because in the end, the people that it matters to most are the patient, the treating team, and I hate to say it, but it's actually the people that like to do sports betting that care the most about it, because they want to decide whether to bet or not. And that's kind of unfair. You want to leave the health up to the patient. And that's probably the most important thing. Betting against someone because they have an injury is kind of unfair. But that's the world we live in. Okay, and I'm not making any judgment, but I'm just sort of saying, putting it in the context of imagining myself as Maxx Crosby with an injury and finding out that everyone's betting against me. Oh, that would make me feel, oh, I didn't like that. Don't throw that reaction expression. He's going to keep it in.
That may be the thumbnail.
That's going to be the thumbnail. So anyway.
Maybe that one.
So... yeah, it's funny because if I were to look at my videos, I think it's like most of the time they're all these like funny expression that Joey catches, and I'm never smiling. Maybe once. Anyway, it doesn't matter. You guys care about me. That's all that matters. That's why you're here. That's why you're listening. That's why you're watching. So, getting back to what happened, 2 months of slow recovery. Did he have a meniscus repair? And they're calling it a cleanup because that it was a decision they decided to do. I'm not sure what the legality or implications are to say that it was a cleanup if you had a repair. But say you had a cleanup, but it was a pretty significant meniscus tear. There are times where in patients, I've had to make choices where it's worse than it looked, but not enough to warrant a repair, but you don't want to take out all that meniscus. And then you have to then decide, well, It all depends on what you agreed with the patient to do. What did the consent show? In your discussion with the patients, I've had discussions and I tell them, if I go in and I find this is worse, do you want me to just do the cleanup and see how you do and then later decide after you recover to go in and do the more major procedure? Or do you want me to do everything right away? Because if I do everything right away, if this is the finding, again, it's a probability logic flow matrix. We are naturally intelligent in that manner. Don't ever lose that as a human being, okay? So you have to have that conversation with the patient because ultimately the patient is who you're treating. It might be a body part, but it's an intelligent human being that you as a physician have the benefit to take care of, okay? And so we never want to forget that. So in the conversation, maybe it was like, you know what, if it's really bad, let's leave it alone, let's see how it does, and then go from there. It's just a cleanup. I don't want to spend that much time in recovery. What if it was a root tear, significant root tear, where you just trim it, and maybe later it turned out to be more significant, and what if it was a cleanup that resulted in more than 50% or 2/3 of his meniscus? So then he gets seen, it's like, oh, okay. Now we see a new tear. We see some degeneration in cartilage, meniscus. I am concerned he could lose his meniscus, may need a meniscus transplant. This is not what we signed up for. So you can see the workflow and the logical, sort of decision-making process that they may have gone through. Again, we don't know that, but there are definitely valid reasons, logic, rationale, and recommendations based on the overall probability matrix of things that can happen that could result in a decision by the physicians and the team to say, we no longer want Maxx Crosby. Now that's unfortunate, but everything has a way of working out, and maybe this is better for him. I don't know. I don't have a crystal ball. I have a Charles, and we'll bring Charles back in when it's right for him. Because Charles is the decision maker for his knee, because that is his knee. Still no word. He's being so quiet. Anyway, okay. So any questions?
What would you say the percentage of NFL players, and this is a defensive lineman, so this is a violent position.
Oh yeah.
So as a defensive lineman, what would you say the percentage would be for people that have degenerative knees?
So the percentage of defensive linemen that have degenerative knees, I think you really have to get across the spectrum of age. Like, are we talking the young new recruits or across the spectrum or at the end of the career? If they're at the end of the career, I mean, I don't like, pigeonholing myself into a number, but it's definitely going to be more than 50%.
So like let's say 5 years in, 5-6 years in. So they're good enough to still be in the league.
Yeah, so it's hard to put a number on it because not everyone who has degenerative changes will actually have x-rays or imaging or an injury that warrants an assessment, right? So it's kind of like, I'll give you the best example is runners. Like runners brutalize their knee and they run for years and they feel great, and a family doctor gets an x-ray of the knee and they say, oh my God, you have horrible arthritis and it's in both knees. Well, the arthritis didn't suddenly appear. And the runners will often say, yeah, but I mean, dude, I just want to be able to continue running. I mean, I run 10 miles a day or 15 miles a day. My knee doesn't hurt that bad. I don't need a knee replacement. But sometimes there's a disconnect between what the image shows and what the health of the patient and the symptoms in the patient. So we cannot always assume that someone who is still playing doesn't have arthritis, even if they've never had imaging that shows otherwise. So that's the caveat. But if I were to say 5 years in, I mean, one thing I know for certain is that more than 50% of linebackers, especially the defensive linebackers, blow out their PCL. So they have some instability. So if they have instability, then you're going to say more than 50% will have a risk or have some form of, I would say some type of post-traumatic cartilage, chondro, arthropathy. Now, I don't want to say degeneration, because the problem is that degeneration automatically assumes that it was not related to some type of trauma. This is some type of trauma that us as other humans in our separate jobs will never go through. So it is a traumatic, is it work-related injury? Is it a repetitive stress syndrome? Is it a repetitive traumatic cumulative trauma? Those are all the variations of what we could call it. But I would say, hazard to guess, the easiest, especially on camera, would be to say that across all defensive linebackers, more than 50% would have some type of arthropathy, whether it's cartilage, degenerative, what kind of cartilage, whether it's the chondral or whether it's true joint space narrowing, to some degree in their career. So, and that is the pundit's answer to that question.